Somos una institución líder en Colombia y América Latina. Nuestros procesos están certificados bajo estándares nacionales e internacionales. Hemos sido pioneros en la implementación de protocolos de atención y diagnóstico. Nos complace ser un referente en la atención médica de alta complejidad. Contar con servicios clínicos calificados con excelencia. Tener médicos e investigadores que publican en revistas especializadas. Somos el hospital universitario más importante de Colombia y contribuir desde la investigación al desarrollo de la ciencia médica. Pero lo que más nos importa es eso que nos alienta, el bienestar de nuestros pacientes y sus familias. Fundación Valle del Lili. Excelencia en salud al servicio de la comunidad.
Welcome. On behalf of Fundación Valle del Lili, we invite you to participate in our Cancer Registry Symposium. This event will be held virtually on October 20th. The importance of registering allows us to understand diseases and their behavior better. This greatly impacts our knowledge of tumor biology, therapeutic strategies, and health policies.
We have the support of recognized organizations, American Society of Clinical Oncology, the Colombian Association of Hematology and Clinical Oncology, and Universidad ICESI.
Experts from IARC, NIH, Yale University, Registro Poblacional de Cáncer de Cali, and Fundación Valle del Lili will also be participating. We look forward to sharing with you this exciting event so that together we can initiate an era of building quality cancer registries.
Good morning, dear colleagues, undergraduate and postgraduate students. Okay. Good morning, dear colleagues, undergraduate and postgraduate students, faculties, cancer research, registers, administrative, and medical staff. First of all, I would like to thank all of you for participating in this academic activity led by the Department of Oncology and Hematology. On behalf of Fundación Valle del Lili, we welcome you to this symposium on cancer registries and their impact on cancer control. This event aims to incentivize and raise awareness of the need to create and strengthen cancer registries in Latin America and the Caribbean. A cancer registry is an information system designed to collect, store, analyze, and access a given population cancer data. This activity is consistent and strictly developed over time, thus ensuring new cases identification and capturing and updating these already include. Collected data represents a primary source of epidemiology on the determinants of cancer and the planning and evaluation of health services. It also enables us to know the evolution of neoplastic disease through time and the impact of treatment on survival. In addition, they positively affect the patient's diagnosis and treatment by strengthening the foundations for multidisciplinary management and optimizing diagnosis methods. There are two types of cancer registers. The first one measures disease impact in a specific demographic area, known as population-based cancer registry. The second one evaluates the burden and quality of healthcare services and the organizational and administrative support of a given hospital, known as hospital-based cancer registry. The history of cancer registries began in 1900, where the first data on attempt to register appeared in Germany. However, only until 1926, the first record of neoplastic disease was established in Hamburg. Then, in 1940, a registry was established in New York. This example was followed by countries such as Denmark, Hungary, the Netherlands, Iceland, Portugal, Spain, and Switzerland. From Latin America and the Caribbean, the history began here in Cali, Colombia, thanks to the leadership of Pelayo Correa in Universidad del Valle, with the support of William Hansel. Everyone remember Dr. Correa for epidemiological studies on gastric cancer, and also Dr. Hansel for their work on the first national system to track cancer cases and their possible causes in the USA, the surveillance, epidemiology, and end results served. By 1955, approximately 20 cancer registers was established in several countries. Then, in 1966, International Association for Cancer Research on Cancer was founded and standardized the data collection methodology. Nowadays, there are around 200 cancer registers worldwide, covering only 5% of the world's population. In the vast majority of countries, such as Colombia, India, Italy, and USA, registry only cover a portion of the population. Some other countries are only targeting a specific population, like the Oxford UK Childhood Cancer Registry, as well as some particular neoplasms, such as gastrointestinal cancer registry in Dijon, France. Nationwide, registries operate in some countries, such as England, Wales, Scotland, Nordic countries, Canada, Australia, New Zealand, Israel, Puerto Rico, and Cuba. The Danish Cancer Registry, founded in 1942, is the oldest functioning registry covering in the entire country. Population-based registries help build a framework for disease control and in turn seek to have an impact on the community. So the emphasis is epidemiology and public health. Within their benefits, we can find that registries help us. First, decrease the extent and nature of disease burden in the community. The second, establish public health priorities. The third, become a source of material for etiological studies. Finally, assist in monitoring and measuring the effectiveness of cancer control activity. Now creating and maintaining cancer registries may come with the many different challenges. For example, while in developed countries, registries may have data such as etiological causes, but in low middle income countries, we may find barriers that often do not guarantee data quality. Some examples of these barriers are the first, limited availability of economic resource, and the second, insufficient training of staff intent for data collection. And the third, lack of necessary information, especially in individualized care sites. And the fourth, inappropriate denominators such as out of date censuses, population mobility through political conflict or forced displacement from violence. Coverage of urban population and little coming from the rural area. We decided to focus this symposium mainly on hospital-based cancer registries because Fundación Valle Lili has made an historical commitment from Colombia and the region, creating a hospital-based cancer registry since 2018 with the sole purpose of improving the outcome of cancer patients and consequently creating the institutional cancer control program, as well as to take advantage of this opportunity to encourage new registries in the region and thus improve cancer statistics and establish strategies that contribute to the disease control. As you can see, the challenge that we are now faced with us to include these cancer registries as on one of the City Cancer Challenge initiative objectives so that we can strengthen our surveillance. We would like to express our gratitude in advance for the support provided by the Cali Cancer Register and Yale Cancer Center Tumor Registry in developing our registry. Likewise, we thank ASCO for its invaluable support in this process. Today, we will have the opportunity to listen to experts in this area from well-known institutions in this field worldwide. From the IARC, Dr. Marion Piñeros. From Yale Cancer Center Tumor Registry, Teresita Vega. From NCI, Dr. Sherman Negoita. From CARPA, Dr. Glenis Albreton. From Registro Poblacional de Cáncer de Cali, Dr. Luis Bravo. And from Fundación Valle de Lili, Dr. Fernando Rosso. Thank you for joining us. Okay, and now we will have the opportunity to listen our faculty. Our first faculty is Dr. Piñeros. Dr. Piñeros earned her MD degree from Universidad del Rosario and her Master of Science in Public Health from the University of London. She worked in Colombia for around 10 years and in the last 5 years as a science at IRRC. Welcome, Dr. Piñeros.
Thank you very much. Can you hear me well?
Yes?
Okay. So, Angela, thank you very much. I'm very pleased to participate in this symposium, and on behalf of IARC and director and my superior also, we want to extend the thanks to give us this possibility. So in this 20 minutes, I will speak very briefly for those that maybe are not aware of our role as IARC in global cancer surveillance, also the rationale for having of data to inform decision making. I will present, as I mentioned, the Global Initiative for Cancer Registry Development, how we work, what are our main streamlines of work. And based on the experience in Latin America, which I know best, I will show some examples of progress and then finalize with some of the challenges that we have seen in this 5 years that the GICR is already working. So for those that maybe don't know exactly, the International Agency for Research on Cancer is a specialized agency of WHO, but we have independent governing council. The key areas of work for IARC are describe the occurrence of cancer, understand the causes, and evaluate and prevention and implementation strategies. So these are like the main 3 pillars. Describing the occurrence globally is one of our aims at the section of cancer surveillance, or briefly called CSU. What do we do in CSU? So our main core activities, we give support to registries, we collaborate with registries. This has been in our mandate since our 50 years of existence. But since the last 5 years, we do it a little bit more organized in the way of GICR, which I will show, working very closely with the International Association of Cancer Registries. Based on that, or the work with registries in collaboration, another area that is very important for CSU is the dissemination of global indicators. Most of you interested in the cancer data will probably have seen the GloboCan and the latest developments of the Global Cancer Observatory, where we have the data for 198 countries, 78 countries. And one of our landmark periodic publications is the Cancer Incidence in 5 Continents, which is a periodic publication of high quality cancer registry data, published more or less every 5 years. So with this information, one of our also objectives and goals in the section is to do descriptive epidemiology research, to bring collaborators, to bring people from many parts of the world together to use the data that are stored and that many of the registries are producing. So it's a circle, and within all our work, we clearly have this data that you might have seen. Our last GloboCan projections for 2018 tell us that there will be more or less 18 million new cancer cases each year, which is really, if you think about now that you have data, seen more and more data from COVID, for example, this is an enormous, enormous burden. For the year 2040, it is expected that the burden will almost double. And what is really very worrying is that 75% of the future burden will occur in under-resourced regions. So these are estimates, and estimates are good and should be used if nothing else is there. But obviously, the best is to have own data. Angela was mentioning, Dr. Zambrano was mentioning about the availability of data. And we can see here in this map, which represents the high quality data from high quality population-based cancer registries that were included in the last volume, volume 11 of CI5. 343 registries all over the world, 65 countries, which is a fairly good amount of data. But if we see, there is a huge inequality in terms of very well developed systems in the northern countries, and the coverage of population-based cancer registries, of high quality population-based cancer registries in Latin America, in Africa, and Southeast Asia is not more than 10%. So with that burden that we have seen, and with that disbalance in the development of good data that are needed to plan, in more or less 7 years ago, a multi-partner initiative created the GICR, Global Initiative for Cancer Registry Development. And this is led by our group, CSU at IARC. So we have a global, regional, and local approach. The idea is that countries can have a guidance that has global directories but is regionally developed. Here we have the regional hub for Latin America, which covers all these countries. All hubs have their particularities, have collaborative centers, have very committed people that are working in it. And all hubs, we do more or less these main 4 streams of work. A big emphasis on training, big emphasis on directed support in order to help countries. Advocacy and networks fostering is very important, to learn from others, to build capacity, to build collaboration, and obviously trying to link all the work of registries with cancer control, which is the ultimate purpose of a surveillance system. So I will explain some of the mainly more what we are doing in training and in directed support. So in order to expand the outreach, because IARC cannot continue to just giving courses in Lyon, and less now with this pandemic, and to make things more in a regional way, we created this so-called GICR net, where our main model is to have the trainers model, so that in the different hubs, there is networks of people that are experts in specific areas. And we will show in which of the areas. We will produce and are producing some material. Is it okay with the sound? Sorry, I was hearing some. Is it okay?
Yes, it's okay.
Okay. So for this GICR net, or for expanding outreach, we are linking also course material together with publications from IARC and IACR. What courses have we done so far from GICR net training courses in the last 4 years? We had one, training trainers for CANREC 5, which is the software that is free of charge from IARC and from IACR for population-based cancer registries. We had one in coding and staging, one in data quality, and one course in data analysis. And we are preparing now, together with St. Jude's, one for childhood cancer registration and specifics on that. That means that from the hubs that participated, we have a series of people in the hubs that are helping and are very committed to help people in the region, so that the outreach of training can be bigger. Here we have the picture of those GICR net trainers that came together on the data quality course. I take the opportunity to really thank to each of them, because most of them are really useful in their region, speaking with the people and handling with difficulties that they know very well. Mentorship and twinning is another of the ways to develop training, because formal training for cancer registers is inexistent in most of our countries. So the possibility that people from less developed registries go and train on the spot and do work has been also very much used in GICR. Characteristically 2-3 weeks stay for one person that is learning in a registry that is well developed. This has helped also very much to expand the possibilities of training. Finally, for the training, we are working very much, and especially now, to try to develop e-learning modules in the moment. So we are developing a series of modules with exercises that will then be translated and used also in multiple languages, and that can be available online for those people interested. And we are developing a best practices portal. Some of the resources are already available in the GICR webpage, which I will show later. With the countries, how do we work with the countries? More or less, and in a simplified manner, this is a scheme where we have a country assessment, or the country calls us for a visit. There is a site visit, which with an expert that many of the times is a regional expert. We do an in-depth evaluation of the registration practices, but also very careful of the commitments of the stakeholders and governmental policies that can help cancer registration. Each site visit has concrete recommendations from which the registries or the government can work with, and we do directed support, tailored solutions, especially for the countries which my English, something came, especially with countries with whom we have agreements, because we try to ensure that there is a commitment not only from our side, but also from the country. And finally, to generate evidence. But what is really behind is that we really want that countries lead their own plans. We are a facilitator and we want to support countries, but it is a responsibility of the governments and of the countries to lead their plans to strengthen and better inform cancer control. With that said, and more or less shown very briefly, GICR activities, I want just to mention briefly some of the progress GICR in Latin America. For our hub, we have these collaborating centers, which are the National Cancer Institute in Colombia, the National Cancer Institute in Brazil. These two cancer institutes, as well as others in the region, are very working together with the government and the Ministry of Health to support cancer registration. Not that they are leading a population-based cancer registries, but support and guide somehow the development of population-based cancer registries. Comisión contra el Cáncer in Uruguay, which is leading the National Cancer Registries of Uruguay, a high-quality cancer registry, has been also one of our collaborating centers, very much focused on mentoring and twinning, and a very strong support, especially in the early years, from the National Cancer Institute of Argentina. Training, as I mentioned, many courses, less than we had expected, more or less one big course, regional course a year. Mentorships, which were mainly focused for countries that had no registry in Central America and Paraguay from South America. Online transmission of local courses. There are local courses that are being held and organized by each country. So we have also tried to support that these courses are transmitted online. For the site visits, all the countries that you can see here in violet have been visited at least once or twice, even some of them 4 times in the last 5 years. And follow-up is crucial to work with them. We have specific agreements and are working very closely with El Salvador, Mexico, and Paraguay. We had a country agreement also with Panama. Another stream or development where we have focused some effort is trying to produce some evidence and research using either the situation or the data from countries. This has been interestingly evolved in the last years with the contribution of our collaborator, the Pontificia Universidad Javeriana from Bogotá, and linking with universities, I think, will be one of the ways that we can advance more. So we have worked in showing advances in cancer registration in the region, illustrating the value of partnerships, and giving also some examples of what you can do on a regional basis, either just describing the burden and patterns, which is extremely helpful for planning and evaluation, using special populations or describing by type of cancer, or also using 1 or 2 registry data. Here is a table. I will not enter into detail, but we just submitted with help of all our collaborators of the hub, trying to illustrate a little bit what we have learned this year and what advances have been done. And I wanted to highlight that in 2015, Dominican Republic had nothing, El Salvador also nothing. Today, they have started their population-based cancer registries, as well as Honduras. Mexico, that had at the moment 2, one of them very pathology-based, has in the moment a registry cancer network that has 10 population-based cancer registries in the countries. And the percentages of population covered is also increasing, because this is Central America. I'm not going to show for South America. So what has shown us the experience and the time so far with GICR? What are the main challenges? I think that the first challenge on the local level is understanding that PBCR is a distinct surveillance strategy. And I think this is something that is not minor, because our countries and low and middle income countries have so far built a strong experience in surveillance of transmissible diseases. And somehow people think that they can transport the model of transmissible diseases to cancer, which is not the case. It is not the case. I will not enter into the full details, but for many aspects, it cannot be as such, because of the magnitude, because of the type of disease, because you need months or a strong workup to know if it is a primary, from where it is. So you need a lot of detailed information. So based on that challenge, we produced this leaflet, which is a brochure of 2 pages that you can find also in GICR, directed mainly to governments, saying these are the essentials and why is PBCR so critical. Another big challenge is the competing priorities. Obviously, governments have many priorities, but something that is closely linked is the long-term planning. We are not accustomed, and many of the are not accustomed in long-term planning and just want what can be done today. The other challenge is the quality of primary data. It's very variable, but in general, bad. And I think that as a faculty, and probably many of those that are listening today are students, and yes, they spent a lot of time on clinical records, but the quality of what they put in the clinical record for PBCR is critical. And this goes along with the IT solutions. And this can show a whole range of developments. More and more, especially in Latin America, institutions are having standardized and electronic clinical record, which is not the case in many parts. But it's also something that we need to develop better and see how to link that with the population-based cancer registry and how to minimize the work of the registrars or to improve the work of the registrars. The other big challenge is the dissemination and use of the data and the timeliness. Really, while we were very much focused in trying to help the development of new registries, we also saw that the quality in Latin America, there are 98 population-based cancer registries, but the quality is really, of many of those, not what it should be. On the regional and global level, big challenge, the funding. We would like to have really more funds for our collaborating centers, for the people leading the hubs, so that they can also support local data collection. And we are working sometimes really under some budgetary constraints. And the big challenge that all of you know for 2020 and that is affecting us all is COVID. This is the results from a survey of registry operations. This is the responses of affected. So in the Americas, 84% of the registries that responded feel themselves it was affected. And I think, yeah, it is really crucial, and we don't know how this will further affect. So that was more or less my big overview of GICR. I invite you all to explore not only our webpage and the Globocan and GCO, but also this webpage. Of course, it can be improved. Some information needs to be updated, but you will find good resources also here in the library and resources section. Thank you very much to all of you. And okay, Angela, thank you.
Dr. Piñeros, excellent conference. Thank you. And now we have our next faculty, Dr. Servan Negoita. Dr. Negoita is the Chief of Data Quality Analysis and Interpretation Branch at NCI. Servan earned his MD degree from the University of Medicine and Pharmacy in Bucharest, Romania, and his DRPH from the State University of New York. During his 25 years in cancer surveillance and public health research, Dr. Negoita served in various roles. The areas of expertise are cancer registry operations, cancer data quality assessment, and racial ethnic disparities in cancer treatment. Welcome, Dr. Servan.
Thank you, Angela. Thank you for having me here. I'm representing the National Cancer Institute of the United States, and this morning I will try to present the cancer surveillance system in the United States from the perspective of the central cancer registries. And the main goal of the presentation is to provide an overview of the surveillance system. My presentation will include three sections. The first section, I will discuss the structure of the surveillance system in the United States. Then I will follow with providing information about the process of the surveillance, cancer surveillance in the United States. And I will finish covering the outcomes of these surveillance activities. And let's start discussing the structure of the surveillance system. On my next slide, you see the components of the cancer surveillance systems in the United States, and that includes the hospital registries, the non-registry hospital reporters, other healthcare delivery and health insurance entities, the central cancer registries, federal programs and standard setters, the vital statistics system, and the census system that provides population estimates. And I'll briefly touch on each of these components of the surveillance system. So starting with the hospital cancer reporting, there are approximately 22,000 facilities or healthcare facilities accredited in the United States, and 4,000 of these are hospitals. Now, 1,500 of the 4,000 are accredited by the Commission on Cancers, in order to obtain this accreditation from the Commission on Cancer, you need to support a hospital cancer registry. Approximately 60 to 70% of all cases diagnosed in the United States every year are diagnosed in these accredited hospitals, and therefore are reported by the hospital cancer registries in the Commission on Cancer accredited facilities. Now, there are about 2,500 hospitals that are not accredited by the Commission on Cancer. Nevertheless, they are required by law to report. And altogether, hospital reporting from accredited and non-accredited hospitals cover about 90% of the cancer cases diagnosed annually in the United States. So both hospital registries and non-registry hospital reporters collect information for these newly diagnosed cases, and they create abstracts, electronic abstracts that include patient demographics, tumor characteristics, cancer staging, first course of treatment, and outcomes such as survival or recurrence. These abstracts are then transmitted electronically to central registries. And I should say, like in United States, we use central registries to describe the population-based cancer registries. So abstracts are submitted usually every 6 months to the central registries. And a few words about many non-hospital reporters that are still required to participate in the cancer surveillance system. One such example are the pathology labs. They are required by law in most states to transmit the pathology reports, the text of the pathology reports to central registries. One such example is California, where a law passed last year require 100% of the pathology reports to be submitted electronically to the central registry. And overall, at least for the registries that receive funding from the National Cancer Institute, we have at least one pathology report for about 80% of the newly diagnosed cases. Some cases will have obviously more than one pathology report. In addition to pathology labs, ambulatory surgery centers, radiation therapy centers, and in most of the states, physician offices are also required to report to central registry, as well as the health maintenance organizations. Now, speaking about the central cancer registries, again, we use the term central cancer registry for a population-based cancer registry. And there are more than 60 population-based cancer registries that cover 100% of the US population. They have been established and they function under the state law. So it's not the federal law, it's a state law. And each jurisdiction in the United States passes a law that make cancer reportable. And these state cancer registries have partial funding from the federal government. So typically there is like one central cancer registry per state. But there are some states where we have regional registries. One such example is California. So 100% of the population in California is covered by the three regional registries that function in California. So typically a central registry, it's a program with the Department of Health, but some Department of Health contracted the registry operation to universities or private research organizations. At the federal level, we have four major organizations that we refer to them as standard setters. One is the Surveillance Epidemiology and End Results Program of the National Cancer Institute. This is the program that I'm working for. Our sister agency, the Centers for Disease and Prevention, the CDC, supports the National Program of Cancer Registries. And then the North American Association of Central Registries cover all central registries in the United States and Canada. In addition to this, the National Cancer Database, it's a non-governmental organization. It's supported by the Commission on Cancer, and they are another, the fourth major standard setter in the United States. And these four organizations work with other major partners in supporting cancer surveillance, and the other major partners that I listed here are the American Joint Committee on Cancer, the College of American Pathologists, and the National Cancer Registrars Association. Now, another component of the surveillance system is a vital statistics system that provide mortality data. State and territorial vital statistic offices provide certificates. Most, if not all, the certificates are transmitted to central registry in an electronic format. In addition to the vital statistics system, information about deaths are provided from linkages with Social Security Administration. This is the pension system in the United States. And also the National Center for Health Statistics, which is a division of the CDC, compiled national cancer mortality statistics. And in addition to this, compiles a national death index, which is used by central registries to link against and to obtain information about the deaths of patients who were diagnosed in one state but died in a different state. So you have this problem because of the population mobility. A cancer patient might not die in the same state where it was he or she was diagnosed. And the way to find out and have complete survival statistics or have a passive follow-up is like to link against the national death index. And of course, you need the population estimates in order to calculate the incidence and mortality rates. And these population estimates are provided by the Census. The Bureau of Census is part of the Department of Commerce in the United States, and it provides annual population estimates by certain demographic characteristics required by law, such as sex, age, race, and ethnicity. And I'm moving to the middle section of my presentation, where I will talk about the process of cancer surveillance in the United States. And we'll start with speaking about cancer registrars, who are the backbone of cancer surveillance. There are over 6,000 cancer registrars in the United States. Most of them are certified. They have the CTR, the Certified Tumor Registrar credential, and this credential requires post-secondary education, meaning college education, work experience, and passing a national examination. Cancer registrars work in both hospital and central registries, and they collaborate very closely with pathologists, epidemiologists, hospital administrators, and other healthcare providers. And they conduct most of the case finding procedures at the hospital level, and non-hospital reporters conduct case finding procedures trying to identify tumors that could be reportable by screening the ICD-10 codes in the electronic medical records of hospitals, by looking for cancer ICD codes in pathology reports, by reviewing the text of the pathology reports, by screening the hospital discharge codes. These are ICD-10 codes in the United States, and also screening treatment or procedural codes for for treatments or procedures that are usually associated with cancer. And in addition to this, registrars review pathology reports, and then they use the pathology reports and the information from the EMR in order to create abstracts. In addition to this, registrars will receive, as I mentioned before, information, death certificates from vital statistics, and sometimes by linking the information from vital statistics with central registry, you identify missing cases that are referred to as the certificate-only cases. So once a tumor was identified, then the question is whether the tumor is a reportable disease and in the United States or not. And in the United States, cancer is a reportable disease because of state public health law in all US jurisdictions. And usually the regulation about what is reportable and what is not are based on the ICD-03 site, histology, and behavior codes, or based on ICD-10 codes. Generally speaking, in situ and malignant behavior is reportable for almost all tumors, maybe with exception of non-melanoma skin. Also, in addition to in situ and malignant behavior tumors, the benign tumors of the central nervous system are also reportable in the United States. Generally, the reportability regulations follow the NACER standards, again, the North American Association of Cancer Registry standard. And you can see here the web URL where you can find more detailed information on reportability. Now, once it was decided that the tumor is reportable, as I mentioned before, the registrars will abstract information about the tumor following the NACER standards, which are a common set of rules and definitions for abstracting, which cover over 500 data items. Now, each national organization will require the hospital and non-hospital reporters to use some of these 500 data items. And at the end of this abstracting process, electronic abstracts that include both coded data elements and semi-structured text will be transmitted periodically, usually within 6 months from the date of diagnosis, to central cancer registries. Now, we'll talk a little bit about the central cancer registry operations. The first thing the central registry will do will be to review the accuracy of coding by looking at information from text, from pathology reports, from other sources available at the central registry, and verifying the accuracy of coded data items. And if necessary, will resolve any logical inconsistency between the different coded data items. Next, because it is likely that for each tumor, a central registry will receive one or multiple abstracts and, as I mentioned before, one or multiple pathology reports. The central registry will try to match and link all this information, all these data sources that correspond to a patient, and even more precise, that correspond to a tumor. Because if you think about this, a patient may have more than one tumor, and maybe some of the abstracts and the pathology reports refer to tumor A and some other to tumor B. So basically, there is a very complicated linkage mechanism that tries to establish the right relation between a pathology report or an abstract and the correct corresponding tumor. There will be additional linkages performed at the central registries that will bring in pharmacy data, as I mentioned before, death certificates, all the results of molecular testing, as an example. And once all this information is available, the central registry will perform the consolidation step, which is basically integrating and taking into account the information from all these sources and selecting the best value for each of the 400 or 500 data elements that will be transmitted to the national organizations such as CR, NPCR, or NACER. But before sending the information to the national organization, the information, the abstract, will be stripped of the personal identifier. So basically the information that will be transmitted to federal government or to the or to NACER will not include name, social security number, address, date of birth, or anything else that will allow for a specific patient identification. At the national level, CR, NPCR, and NACER develop national and international standards, such as the NACER standards, and you can see here the link for each of these examples that I am providing here, and I selected the four set of standards, manuals, and the CR Educate tool, which are downloaded by a relatively large number of people outside the United States. So NACER standards are the standards for cancer abstracting and coding in United States and Canada. More detailed information about how to perform this abstraction and coding, it's included in the CR program coding and staging manual, again, freely downloadable. Information about multiple tumors, for example, or at least the rules used for determining the right histology when there are multiple histologies or multiple tumors are included in the solid tumor manual. And CR Educate is a resource downloaded more than 10,000 times at locations outside the United States, because it provides real cases, real pathology reports, and text of other medical documents that can be used to practice oncology coding. In addition to this, national organization conduct quality evaluation for the completeness, timeliness, and accuracy of coding. And we also try to enhance the usability of data by providing automated stage calculations, like, for example, verifying and automatically calculating the TNM stage group when information about T component, N component, and M component of staging are available. And then we release the data for public use. And with this, I'm moving to the last section of my presentation that talks about the outcomes of cancer surveillance. And in this context, when I talk about outcomes, I'm not talking about outcomes such as survival or time to recurrence, but I'm talking about the data products released by cancer surveillance system. And I will start with a brief introduction of my program, the CR program at the National Cancer Institute. This program has been established in 1972. So we are in year 48 of existence, and the program covers approximately 35% of the US population. And we try to collect in-depth data that can support oncology research above and beyond what is collected by ZIA's surveillance programs in the United States. Our sister program, if you want, it's supported by the Centers for Disease Control and Prevention, the CDC. It is called the National Program of Cancer Registries. And between programs, the CR program and the CDC and the NPCR program at CDC, we cover 100% of the US population. And this map depicts that and informs that some registries are supported by National Cancer Institute only. Some states receive the states in hashed blue, light blue, are supported by both the CDC program and the NCI CR program, and then all the other states that are darker blue are supported by the CDC program. But at the end of the process, the data from both CR and CDC are put together, and we create the United States cancer statistics, which are the official federal cancer statistics. And you can see the web location where you can download the official United States cancer statistics. And I'm providing here just like one example of this very nice data visualization tool developed by our colleagues at CDC. And in this particular example, I'm showing the rate of newly diagnosed HPV-associated cancers by state. And on the right side of the screen, you see that the highest incidence for HPV-associated cancers is in the southeast United States. And on the left side of the screen, for example, you see the exact incidence rates for each of the different types of cancers that are associated with HPV infection. And my next slide presents the main data publication of NACER. This is referred to as CINA, which stands for Cancer in North America. And basically, NACER is compiling and putting together the incidence, mortality, and survival statistics for both United States and Canada, and it's creating basically the statistics for North America. And I'll finish my presentation with a few slides that describe a CR Explorer. That's a web tool that, again, it's accessible from anywhere in the world. It's a web tool that was developed to help researchers and the specialists involved in cancer control. It does not require in-depth programming knowledge, so it's basically an interactive tool that makes it easier for, let's say, practicing oncologists or for the patient to get more detailed cancer statistics information. So we present the information not only like in terms of incidence or mortality for all tumors of the digestive system or for all tumors of the esophagus. But for example, we try to go more in depth and to present statistics for adenocarcinoma of esophagus versus a squamous cell carcinoma of the esophagus, because these two are disease entities with different treatment and definitely very different staging and prognosis. And also, in addition to the traditional incidence and mortality statistics, we try to provide more for public health officials by including statistics on the prevalence of cancer and on the risk of diagnosing a new a new case of cancer or the risk of someone dying from cancer by geography and by time. And I will end with just two examples, more specific examples of how this tool can be used. For example, a practicing oncologist may receive a question from patients about survival with metastatic luminal B breast cancer, that's ER2 positive, PR positive, HER2 positive breast cancer. And maybe the question is like whether the survival is the same, independent of race and ethnicity. And unfortunately, that is not the case in the United States, where the Blacks and Asian Pacific Islanders have a lower survival than the rest of the US population. And while the data are presented here in a chart, you can download the data in a table and have the exact survival numbers and the confidence intervals. And my last example is like, for example, how the tool can be used if a public health official would like to know how many lung adenocarcinoma survivors younger than age of 50 are alive in the United States and plan for services that are required by such patients. Again, our interactive tool offers an easy way to find an answer. Again, I'm presenting here the graph, but someone can download the exact counts and the confidence interval around these counts for this very specific oncology question. So thank you for inviting me to present this morning. I will stay with you for the rest of the presentation and will take any questions at the panel that will take place, I believe, at the end of this session. You have my email here. Please don't hesitate to contact if you have questions. And thank you again for being with me this morning.
Thank you, Dr. Servan, for this amazing presentation. Our next speaker is Teresita Vega. She is a manager cancer registry in Yale New Haven Hospital. She started at Yale in 2000. Is responsible for the capture and collection of patient data from the moment of the diagnosis until patient passes away. Welcome, Teresita.
Thank you so much for having me today. It really is an honor to be a part of this group. I really appreciate the work that everybody is doing, and I hope it continues and I can be a part of it in some way at any given time. So we're going to just begin by the objectives. I'm going to try and go through this a little bit quicker so that we can try and catch up a little bit here. So I have three objectives, the first being the overview of the cancer registry history, which I'm going to go through very quickly as it has already been described. I'm also going to talk about the cancer data that has to be collected and the purpose and importance of cancer registry data. I think we've already heard about the importance of quality data, and I too will stress quality. I wanted you to all see where I live and where I reside. I am in Connecticut. I hope you can see it on the map there. Just to let you all know, we started this morning with a little bit of snow. So we are experiencing our first snowstorm of the year. Again, this is the cancer registry history that I think has been already described in depth. You can have this for your reference. My main point here is that in 1926, Yale New Haven Hospital established the first complete hospital cancer registry. I actually have data from 1900 to present. Again, just to emphasize here, there are a lot of countries and a lot of areas attempting to capture cancer data. And finally, in 1926, with the main push from the Yale physicians and trying to pass regulatory requirements in cancer registry, they decided to concentrate on the easiest part, which was to create a hospital registry local. They later expanded to go to the state registry and obviously further in the US. So had it not been for technology, even back then, we would not have been able to initiate a cancer registry. It was due to the census that the technology was created from the IBM. And what you're looking at is actually the first cancer registry here at Yale New Haven card that was critical in establishing our record. These are called punch cards. So again, oops, sorry about that. Got to go forward here. Again, technology today, I think you've all mentioned it, the modern computers, the interoperability of the HL7, the electronic health record was instrumental in allowing our team of 30 registrars at Yale New Haven to be able to abstract cases from across 5 hospital systems within the state. So the cancer registries, as you know, collect and process and analyzing the data, but the data comes through every different direction. And cancer registrars are the data information specialists that have to take and manage all of these data. The cancer registrars, I think you're experiencing that we have to be champions of change. And I love Winston Churchill's note that he says, to improve is to change, but to be perfect is to change often. And I think that is so true in the cancer registry field. So where are our data sources? Today, everything is electronic. Historically, a lot of this was manual, which obviously takes so much work. And there's also a lot of reciprocity. For example, as mentioned by Dr. Nagoita, the Connecticut Tumor Registry, we provide data to the Connecticut Tumor Registry for all of our cancer patients. In turn, the Connecticut Tumor Registry provides us data, and they provide us death data. They provide us some follow-up data because they have access to information such as not only Social Security death indexes, but they also have access to the local state motor vehicle licenses, driver's licenses, and things such as that. And so very often, while you see the arrow pointing at the data source to be coming to the cancer registry, it should actually point in both ways, because there are often times in which this is a reciprocity agreement within the group. This is our case finding slide, which I don't want to get into. This is how we do our electronic case finding from our EMR and also from our pathology report. I don't think it's necessary, but you have it, and it has been critical in streamlining the process of case finding for us, all done electronically and with the demographic data downloaded electronically into our cancer registry system. So what's collected? I think we've talked about this a little bit. Demographic data, the age, the gender, race, ethnicity, medical history, you can all read. I'm not going to go through this line by line. Diagnostic findings, the exams, the x-rays, the colonoscopies, etc., all the diagnostic information. Then it's brought into the cancer information to code primary site, the cell type, the histology, the extent of disease. Again, as Dr. Nagoita mentioned, the extent of disease from SEER is what we focus our information. Cancer therapy, how is this patient treated by surgery, radiation, systemic therapy? And others, right? We also have a lot of different radioablations and things like that. And most important, and I think key at Yale New Haven Hospital, is the fact that we provide surveillance data, the follow-up, the annual information of treatment, recurrence, and vital status. In addition to that, our cancer registry not only captures data from the first course treatment that is known, especially being a Commission on Cancer approved program, but in addition to that, we capture all data that is for each one of our newly diagnosed patients. In addition, we capture data for those patients that are not newly diagnosed to our hospital, but to come to us because of a disease recurrence or a progression of disease. And one very important thing that has been talked about very loosely today, and I'm very proud to say that beginning in April, we began to capture COVID-19 data within our cancer registry. In order to do so, I actually had to customize fields. The rest of the country regarding cancer registry correlating our patient data with COVID data is a little bit behind. We're actually doing it across our system. So Yale New Haven Health System has been capturing COVID-19 data since April on all of our cancer patients. And again, keep in mind our database database is from 1926. So it's not only the newly diagnosed, but it's any patient with cancer that has a COVID diagnosis we're capturing. The quality review. So this slide, I am going to take a moment or two on this quality because I think everyone has mentioned it, and I'd like to stress it over and over again. You see, if the data quality doesn't exist, we all might as well go home, because the reporting, the research, everything that follows behind the cancer registry information will be totally worthless. So the emphasis has to be on ensuring quality of data. I am very, very fortunate that I have a quality coordinator for our cancer system. And this has been a paramount process and an ongoing, never-ending process throughout the 20 years at least that I have been here. My suggestion is that you consistently do a random review of 10 to 15 analytic cases per abstractor per year, only if that abstractor is an experienced abstractor and understands thoroughly what they're doing. If you have a new abstractor, I continue to review 100% of those cases until I am confident that CTR, that cancer registrar, is totally capable of performing abstracting to using our benchmark. And the cancer data review, as you can see, is pretty much the entire abstract, which certainly has, depending on the cases, probably a minimum of 300 fields, and at any given time, today I've seen patients with cancers, with multiple cancers, and so today we may have one patient with maybe up to 6, 7, or 8 cancers, and so the chart is obviously much more significant when that occurs. You could see that our benchmark data accuracy is 95%, and we do maintain that here at Yale New Haven Hospital. And as mentioned before, we are a Commission on Cancer approved program. We are a SEER program. We are an NCI program. This is critical. I can't emphasize it enough. So I wanted to share with you a little bit of what the cancer registry looked in the past. And on the top right, I guess, of your screen, top left of mine, you could see the hospital in 1926. We've come a long way from that period of time. Today, I'm happy and very proud of being a part of the Smilo Cancer Hospital. It is a separate cancer hospital, 15 floors. Actually, for this COVID crisis that we have had to endure, the Smilo Cancer Hospital was actually converted to a COVID hospital for about 6 months. Today, we are bringing those floors back, and we only have 2 complete COVID floors left, although unfortunately in Connecticut, we're experiencing an increase in cases. We're at about 6% in Connecticut, which is higher than we've been since June. But early in the pandemic, we had over almost 400 patients at one point in time in the hospital. So this is a very modern hospital, obviously, with negative pressure rooms, which is why it was able to be transitioned. And now back with all of our cancer patients and all of our services here. So the final area that I'd like to talk about is the purposes and the importance of cancer registry data. In this area, I share with you that there are so many different areas of the use of cancer registry and the purpose of cancer registry. Research being paramount, right? Understanding the cancer burden and the barriers to care locally for a hospital registry is extremely important, and the cancer control in the public health area. This is what Yale New Haven Hospital care centers and hospitals look like. You can see the hospitals here. Yale New Haven Hospital, Smilo is right here. And then we have other programs, which are physician programs. For the most part, they are oncology programs providing systemic care in these other different areas. As you could see, we are located pretty much around the state, and we continue to make inroads in this capturing of patient data. So here is just a quick example of, here we call and we reference, I don't know how much everyone references analytic and non-analytic. It's mainly a Commission on Cancer term, but to summarize, analytic cases are those that are newly diagnosed, and non-analytic cases are those that have been diagnosed elsewhere and now are coming for disease progression. And so you can see the different hospital facilities there. And so we have a snapshot. This is our latest data from 2019. And you could see the snapshot. In Connecticut, there is about, depending on what you use, if you use the in situs and the bladder cancers as well, but all inclusive, there's about 22,000 cases in Connecticut a year. And you could see that across the system, we have 11,426 cases total across our system. And this is about half of the states. So in a snapshot, you can actually get a lot of information and a lot of work. This is a slide that's obviously not intended for you to look at in any great detail, although you're welcome to do this. I provide this information in the annual report simply because everybody is always asking, and we always keep our data in SEER group, SEER disease group, primary site, and then it gives us a snapshot. In this case, it's a combined data of analytic and non-analytic. In other words, all brand new cases that are coming to us in those first year of contact, 2015 to 2019. This piece of information, and this is the analytic, which is the newly diagnosed cases alone, gives you a sense of the volume and how much activity and work and programs are provided here at Yale New Haven. We work very closely with the Connecticut Tumor Registry. We work very closely with SEER, Commission on Cancer, etc. And all of our physicians, our researchers, and all of our team at Yale New Haven. We're getting close to the end, folks. I just wanted to share a little bit of different things and not only research, because I think locally hospital registries can offer a different perspective and a very important role. And I'm told, at least here at Yale New Haven Hospital, I still have my job after 20 years. So something right must be going on here. And this type of information is always provided to our executive leadership at the hospital level, at the planning departments. And you could see here that this is a table of just how much of a percentage share we have at different counties. Highlighted is New Haven because we reside in New Haven County. And you could see that we have a 66% estimate share referenced with the cases in Connecticut. Also very important for so many different aspects of cancer registry is the race, ethnicity, and age of diagnosis. Race, ethnicity is a discussion all the time and sometimes so important so that we can target specific areas and demographic data, right? Because we do have all that information. And so this information is so important so that we can get funding to help support our needs within the hospital. So it's really, really important for us to maintain this type of information. So what's the take-home message? The cancer registry is definitely a part of the business world, but it cannot work alone. It must work as a team at the local level, at a state level, if that exists, or at a regional, and finally at a national level. And I like this little saying, you can do anything. We're always told that. You can do anything, but not everything. You need a team to help you work the registry. So accurate documentation is absolutely the right thing for researchers, for regulatory agencies, for cancer registrars. And the reason why we're here is for our patients. It's a tribute to our patients. And I tell everyone who comes to our cancer registry and everyone who abstracts, you should always abstract as if the case that you are working on is of a family member, because it is so important and critical in the work that you do. It is for patients that we are here. So the future of cancer registry is in all of our hands. It's in your hands, it's in my hands. And with that, I really just want to say thank you. We continue to adhere to evidence-based practices and our commitment to providing the best cancer data possibly. And we remain dedicated to our patients and anti-cancer efforts. A special thanks to all of you devoted registrars who work so diligently in collecting the most available and accurate cancer data. Thank you to all of you.
Thank you, Teresita, for sharing with us your excellent presentation. And now we will have a 10 minutes break. Please stay online and send your question to our chat. Okay, welcome everyone. And now our next speaker, Dr. Luis Bravo. Dr. Bravo earned his MD degree from Universidad del Cauca and pathologist degree from Universidad del Valle. Dr. Bravo is a director of Registro Poblacional de Cáncer de Cali since 2001 and is the chief of etiological studies in gastric cancer for around 45 years. Dr. Bravo.
Muchas gracias al equipo de la Fundación por la oportunidad de compartir nuestras experiencias. Saludo muy especial a Mario y a Teresita. El Registro de Cáncer de Cali fue fundado en 1962 por el doctor Pelayo Correa y recibió la asesoría del doctor Bill Hansen, que era el jefe de bioestadística del Instituto Nacional de Cáncer. Para la época, las causas más importantes de mortalidad por cáncer eran cervix y estómago, dos tumores que ahora sabemos están relacionados con agentes infecciosos. Estas son las guías que nos han permitido tener persistencia en el tiempo, limitar los casos a un área geográfica, dedicarnos a contar únicamente los casos nuevos y de las personas que sean residentes, tener transparencia en la divulgación de la información, resolver los problemas con investigaciones. Muy importante tener un patrocinador permanente que ha sido la Universidad del Valle y que los directores tengan experiencia académica y de investigación. Estos son los 4 directores que han estado en los 60 años dirigiendo la parte de morfología. Ha estado Edwin Carrascal y el doctor Cuello, y en la orientación de epidemiología lo ha hecho Pelayo Correa hasta el 2000 y yo desde el 2000 hacia acá, apoyados por el grupo de patólogos del Departamento de Patología de la Universidad del Valle. Cuando se funda el registro de cáncer, el riesgo de cáncer de cervix en Cali era 10 veces más que en Inglaterra. En la universidad se alía con la Secretaría de Salud Municipal, la doctora Nubia Aristizábal, monta un programa de citología que se extiende a toda la ciudad y vemos que a medida que aumenta la prevalencia del uso de la citología, disminuye el cáncer invasivo y aumenta el cáncer in situ. En los 80 se hace un estudio de evaluación mediante casos y controles y se logra documentar que el riesgo de cáncer invasivo es 10 veces más en las mujeres que no se han hecho citología vaginal. 60 años después, el cáncer de cuello uterino apenas representa el 3.8% de lo que son los cánceres en la ciudad. En la década de los 90, la doctora Nubia Muñoz, aplicando técnicas de biología molecular, hace un estudio de casos y controles y compara a mujeres con cáncer en España y en Colombia y logra demostrar que el riesgo de desarrollar cáncer invasivo es mayor en las mujeres que están infectadas con el virus del papiloma humano. Doctor Castillo, hace 3 años exploramos la prevalencia de genotipos 16-18 en 800 estudiantes no vacunadas, comparado con las que habían sido vacunadas, y demostramos que la vacunación protege de los genotipos que están en la vacuna del 16 al 18 a las niñas que habían sido vacunadas. La prevalencia de infección por el virus del papiloma humano era mejor. En la década de los 70 se divulga en Lancet lo que es la cascada de Correa, estudio hecho en Nariño, donde a través de una serie de etapas que empiezan con una mucosa normal, terminan después de muchos años en el desarrollo de cáncer gástrico. En los 90, cuando se sabe que el determinante es la infección por Helicobacter pylori y que los micronutrientes antioxidantes pueden ser una opción, se hace un ensayo clínico, se sigue en el tiempo una cohorte de cerca de 1000 pacientes y se logra documentar que aquellas personas que no se resolvió la infección tienen un puntaje de daño histológico más alto. En contraste, los que hubo resolución de la infección después de 12 años de seguimiento tienen un menor puntaje y ese puntaje disminuye entre más rápido se haga la intervención. Entonces se logra presentar que la quimioprevención puede ser una estrategia en el control del cáncer de estómago. En el siglo pasado, casi el 100% de estos niños tenían bocio. Eso lleva al país a que haga iodización de la sal. Cae drásticamente el bocio y en el entorno los tipos de cáncer de tiroides más frecuentes eran folicular y anaplásico. En el seguimiento después en el tiempo vemos que las formas agresivas de cáncer de tiroides han disminuido y ha aumentado el cáncer papilar. Eso se da porque en la década de los 80 se introduce en la ciudad un método de diagnóstico, mejora las imágenes en esta época, y esto nos explica aquí en el caso de mujeres cómo ha aumentado la incidencia de cáncer de tiroides con una disminución drástica. Cuando evaluamos el país, vemos que para el último periodo, el cáncer de tiroides está entre las principales causas de cáncer en la ciudad. Aquí vemos lo que ha sido la tendencia del cáncer de mama, lo estamos viendo separados por edad, una inflexión en la década de los 80 y 90 asociado con la implementación de la mamografía. En este siglo empieza a disminuir y la disminución se da tanto en las mayores de 60 como en las mayores de menores de 60. Desafortunadamente no hay impacto aún con la mortalidad y la mortalidad sigue sin cambio. En contraste, aquí vemos próstata. Cuando se implementa el antígeno prostático, aumenta la incidencia en mayores de 60 y en menores de 60. La mortalidad disminuye inmediatamente en los menores de 60, lo cual no está relacionado con la introducción del antígeno prostático, pero vemos que la mortalidad en los mayores de 60 disminuye de manera significativa 20 años después. Entonces ya aumenta la incidencia, disminuye la mortalidad y ya vemos que empieza, después de haber llegado a un pico, empezar a descender. No puedo. En los tumores relacionados con agentes infecciosos, cáncer de estómago y cáncer de cuello uterino, tanto la incidencia como la mortalidad han disminuido y esa disminución empezó antes de que se introdujeran y se conociera el papel de los agentes etiológicos específicos. Por lo tanto, está relacionado con mejor de las condiciones sanitarias, con mejor conservación de alimentos. Y vemos que la disminución está dado por los tumores distales que están relacionados con la infección por el Helicobacter pylori y los proximales que están asociados al reflujo gastroesofágico están aumentando. Los tumores relacionados con el consumo de tabaco, aquí vemos en Estados Unidos cómo después de haber aumentado el consumo de tabaco, 20 años después aumenta la mortalidad por cáncer de pulmón. En Cali se aborta este aumento por las campañas antitabaco y tanto la incidencia como la mortalidad por cáncer de pulmón y de cavidad oral han disminuido de manera significativa. Aquí vemos lo que ha sido el comportamiento del cáncer en el sistema nervioso central. Los hombres tienen más riesgo que las mujeres y de manera significativa ha aumentado en estos 60 años. El tumor más frecuente es el glioblastoma y en las mujeres es más frecuente los tumores benignos como son los meningiomas. Estos no han tenido un cambio. Desafortunadamente la supervivencia es muy regular, apenas 1 de cada 3 personas está vivo después de 5 años de haber hecho el diagnóstico. En estas enfermedades crónicas a largo plazo hay 2 componentes que debemos entender para las tendencias. Aquí están el número de casos, de los casos nuevos de la incidencia durante un periodo de varios años, y acá están los casos de la mortalidad. La mayor proporción de incremento en este tiempo de los casos lo da el crecimiento de la población. Y acá está lo que son las tasas y la mayor proporción del incremento lo da el cambio en la estructura asociado al envejecimiento. Tenemos más viejos que antes. Cuando reparamos el efecto del crecimiento y de la estructura nos da los factores de riesgos, o sea que en las tasas, lo más importante es el cambio en la estructura de la población, el envejecimiento y los cambios en los factores de riesgo. La información que les estoy mostrando ha sido divulgada durante los 55 años en los 11 volúmenes de incidencia de cáncer en los 5 continentes, 40 años de información de cáncer infantil y en el estudio de conductor hemos divulgado 20 años de experiencia de supervivencia. En el 2016, 18, 39 autores, publicamos incidencia y mortalidad de 6 registros de Colombia, lo que es manejo de riesgo, en la revista de la universidad que está indexada en Mainline y que está en PubMed Central. El objetivo es proporcionar algunos indicadores de lo que es la línea de base de los futuros planes de la intervención en la ciudad y de los planes para evaluar el control de cáncer del país. En la década primera de este siglo, colaboramos con el Instituto Nacional de Cáncer para que la experiencia de Cali se extendiera al resto del país y ahora ya hay 6 registros poblacionales. La segunda década y en especial en el último quinquenio hemos hecho esfuerzos para que empiecen a funcionar registros hospitalarios y afortunadamente la Fundación Valle del Iris es la experiencia más exitosa y va a llegar muy lejos. Tiene unos principios bastante sólidos, pero la ciudad necesita los registros hospitalarios y el país en las ciudades donde hay registros de cáncer también necesita que haya registros hospitalarios. En el 2009 los hematoncólogos hacen Vigicáncer, que es un sistema de vigilancia al desenlace clínico del cáncer pediátrico, vigilan la recaída, la muerte, el abandono del tratamiento y 10 años después ya está en varias ciudades del país. Este trabajo fue presentado ahora en el 2020 y vemos que los niños con seguro de salud semiprivado tienen mejor sobrevida que los niños con salud con el seguro público. Y cuando se comparan 2 periodos, 2009 con 2013, en ambos sistemas ha aumentado la supervivencia. Pero hace 10 años la diferencia, el punto de porcentaje entre los 2 sistemas de aseguramiento era 26 puntos y ahora, gracias a este programa, en mi opinión, la brecha entre el seguro público y el privado ha disminuido por 50%. La doctora Rodríguez de la Universidad Industrial de Santander hace un estudio para ver cómo se comporta la leucemia en las ciudades donde hay registros poblacionales y logra documentar clústeres temporoespaciales asociados a conglomerados industriales. Un estudio exploratorio que tendrá algunas observaciones y que habrá que seguir en el futuro. Con la pandemia del COVID-19, con la Secretaría de Salud Municipal de Cali, evaluamos la mortalidad de los 15 años, documentamos que algunas entidades, como son las comorbilidades, que dan más impacto en la pandemia, están reduciendo de manera significativa, como es el caso de las cardiovasculares y la diabetes en pacientes de 65 años más, 50 y 64 y 15 a 49. Aquí construimos con el último quinquenio la línea de base y aquí observamos que después de haber declarado la restricción al movimiento, la emergencia sanitaria se retardó el inicio de la mortalidad por COVID, pero ahora es la primera causa de muerte en Cali. Y vemos que independiente de que esos pacientes que están con COVID están muriendo el 20% con diabetes, hay otros que mueren por enfermedades cardiovasculares en exceso. Aquí vemos en cáncer como 7 semanas en exceso y con diabetes. Y yo creo que esta muerte durante la pandemia se relaciona porque los pacientes tienen temor a asistir a los controles, la teleconsulta no funciona de manera adecuada, los servicios sanitarios están colapsados en algunos sitios, bastante congestionados en otros. Y yo creo que en el cáncer lo que vamos a ver es grave y se va a reflejar en el próximo año. También hemos visto cómo es el comportamiento de otra pandemia, como fue la del HIV. Aquí documentamos el ascenso exponencial hasta que aparece la terapia antirretroviral en hombres y mujeres del complejo HIV y SIDA. Y documentamos cómo también de manera en espejo aumenta y disminuye el sarcoma de Kaposi. Estos aumentos se dan 20 años después, o sea que llevamos un atraso de 20 años con respecto a países como Estados Unidos y Europa, donde estos cambios se documentaron mucho antes. Ahora tenemos un reto, que es determinar el impacto de la pandemia en los pacientes con cáncer, en dos aspectos. El efecto directo por la infección, pero más importante, el efecto en la atención oncológica. Para esto nos ha servido mucho esta iniciativa mundial. Cali fue la primera ciudad en acogerse a esta iniciativa mundial, ya está en varios países y el objetivo es aumentar la cobertura y mejorar la calidad de la atención oncológica. Para eso, en los laboratorios de patología de baja y mediana complejidad se han hecho talleres para que mejore la calidad en los histotecnólogos, en los patólogos, con la Asociación Americana de Patología Clínica y con la Sociedad de Oncología Clínica. Los patólogos han participado en la construcción de guías y protocolos. Los hospitales de alta complejidad pues ya tienen acreditación con el Colegio Americano de Patólogos. Además, tienen sus especialidades quirúrgicas y yo creo que todo este escenario garantiza que para el futuro la calidad de la información de cáncer va a mejorar más si se tiene en cuenta que va a haber desarrollo de los registros institucionales. Y finalmente, este es el departamento de patología. Nosotros hemos formado a los patólogos de la región y una de nuestras más jóvenes profesoras, Jimena, hizo el manual de calidad para los laboratorios de patología de baja y mediana complejidad. Hemos impulsado el uso de los informes sinópticos de patología para que haya una estandarización de lo que es el informe en la ciudad. Muchas gracias.
Thank you, Dr. Bravo, for your conference. Okay, our next speaker is Dr. Glenis Albreton. She is an epidemiologist and senior technical officer in non-communicable disease at Caribbean Population Agency, CARPA, in Trinidad and Tobago. Dr. Glenis is for Cancer Registration Caribbean. She aims to build cancer registration capacity in all independent countries and is located in the Caribbean Basin. Welcome, Dr. Glenis.
Thank you. Okay, today I'm happy to be with you and to share on strengthening and sustaining cancer registries, an opportunity for cancer control. Okay, so my presentation today will look at the background, a bit of background, and I will skip some of the slides because Dr. Pineros already touched on quite a few of them. So we'll look at the global burden of cancer, commitments for reducing cancer. We'll talk a bit about cancer registration and control. Then we'll look specifically at the Caribbean region and the efforts that have been made through the Caribbean Hub, which is part of the Global Initiative for Cancer Registration, which is being implemented by IAC. And then we'll talk about how to sustain cancer registration in the era of COVID-19. So we already saw from Dr. Pineros' slides that we have a high burden globally of cancers, and it's projected to increase even more by 2040, dramatic increase, with the major burden being in under-resourced regions of the world, such as Latin America and the Caribbean. So as you may know, there was a focus internationally on non-communicable diseases by the United Nations in 2011. As part of that meeting, which highlighted the major global burden of NCDs and the need to reduce the burden, the WHO developed the Global Monitoring Framework. And in this, the overall goal is to reduce NCDs by 25% by premature mortality from specific NCDs by 25% by 2025. And included among those diseases being targeted are cancer. In order to track whether countries are indeed achieving reduction of cancers, another indicator is included cancer incidence by type of cancer. So based on this meeting, the GICR was developed. And the focus is on cancer registration, which provides access to reliable, high-quality population data on cancer cases. And many of the speakers already highlighted that cancer registration information is required to monitor cancer occurrence and prognosis of cancers within a population and over time, to enable the evaluation of interventions programs such as treatment and screening programs, to look at efficiency and effectiveness of such programs, as well as to facilitate implementation of new interventions for cancer prevention and control. So population-based registries record relevant information on all cases of cancer diagnosed within the target population. It collects continuous and systematic data on occurrences, characteristics, and outcomes of reportable cancers to assess and control the impact of cancer in a defined community. And it allows identification of cancer cases from a defined area to be calculate incidence rates to assess the current and future cancer burden, and as said before, to monitor the impact of interventions. So cancer registries are in fact one of the most developed disease surveillance systems in the entire world. What is the situation with cancer registration in low and middle income countries? And some speakers have already alluded to it, that in fact, we have very low coverage rates of cancer registration in our region. And it is indicated from a publication which Dr. Pineros et al. Wrote, that there's 1.9% coverage in Latin America, and the Caribbean is not even mentioned. So I will focus now on cancer registration in the Caribbean. And for those of you who may not know or be aware of where the Caribbean is located, this slide shows you that the Caribbean is located in between North America and South America, but our countries span from Bermuda in the north to Suriname, which is also part of the South American mainland. So CAFA, in fact, worked with many of these countries. We are just about to have a publication out on cancer registration in the Caribbean. And in that publication, which is in press and will be out in December, we established a timeline for Caribbean cancer registry. And as you can see, we have quite a number of registries, with the first registry being established by Puerto Rico in 1951. And it is what we identified as a high quality cancer, population-based cancer registry. The other high quality population-based cancer registry in the Caribbean is in Martinique, and it was established in 1983. There is another high quality population-based registry in Jamaica, but it's subnational. It doesn't cover the entire country. And we have other population-based cancer registries in different countries of the Caribbean, but we cannot identify them as high quality. And in fact, we are working with them to improve the data quality so that they can be classified as high quality. And we have a number of other countries in red that are under development. Their population-based registries are still in the development phase. So how are we working to strengthen cancer registration in the Caribbean region? And Dr. Pineros mentioned the Global Initiative for Cancer Registry. So I won't speak much of that, but the Caribbean Cancer Registry Hub, which is leading the effort to strengthen cancer registration in the Caribbean region, is part of that Global Initiative for Cancer Registry Development, which is led by the International Agency for Research on Cancer, and is a direct outcome of that meeting, which was held by the United Nations in 2011 to put focus on the burden of non-communicable diseases globally. So you saw this also from Dr. Pineros. Just to point out, in blue, that area in light blue is the Caribbean, the area the Caribbean Hub serves in the Caribbean region. And again, you saw this so that the hub focuses on training, directed support, building of networks, and ultimately works to provide information to support cancer control efforts. So the hub became operational in 2015, and was officially launched in 2018. It's based at the Port of Spain campus of the Caribbean Public Health Agency in Trinidad and Tobago. And we work collaboratively with several key international partners, including IARC, the US National Cancer Institute, the US CDC, the North American Association of Central Cancer Registries, the Pan American Health Organization, and our high-quality cancer registry, Martinique Cancer Registry, which is an IARC collaborating center. The mission of the Caribbean Cancer Registry Hub is to improve the availability, use, and dissemination of high-quality cancer data to inform cancer control in the Caribbean region. And this is just a photo of the inauguration of the hub in 2018. So what have we done since 2015? We have been involved in doing training. We have developed a Caribbean Standard Operating Procedures Manual because we wanted to standardize what is done by all the population-based cancer registries in our region. We have had training workshops on cancer registration, the basics of cancer registration, on use of the CanReg 5 software, on use of the US SAT program for data analysis, and of course, on the standard operating procedures. We have been doing webinars, and we have produced an online training resource listing, which will be available for use, especially in this period where travel is not possible to provide training face-to-face. We are also involved in doing directed support, and you heard Dr. Pinheiro speak about that as part of the initiative of the GICR, So we have gone into countries to do countries cancer registration site assessment. And we have done 6 of those in different Caribbean countries, and they are all on the screen. We have also been assessing data quality at the registries, and we have done 2 such data quality assessments through which we provide guidance on improving data quality at the registries. And we have been providing ongoing CANREG technical support to the countries, to the registries for customization, installation, and use of the software. And you can see some photos of our in-country visits and engagements. We also are participating in establishing networks. So we have a website, and you will be provided with the link on the last slide of my presentation. We are doing continued advocacy, as you heard from Dr. Piñero's presentation. The issue of understanding the importance of cancer registration and the need for cancer registries is something which in our region we feel needs to be continuously advocated for, and we have been doing so. We are part of the Eastern Caribbean Diagnostic Oncology Network, and this is a network which brings together various disciplines in oncology to be able to provide better accessibility to cancer diagnoses and for providing guidance on treatments in many of our small countries that lack some of the clinicians that are, or the professions that are required to do appropriate cancer care and treatment. And we are part of the GICR regional experts, and we have been involved in the data quality training, data analysis training, as well as the training done on coding. And we present the work done by the Cancer Registry Hub and the cancer registries of the region at regional and international conferences. We are also involved in research to try to provide better evidence for planning for cancer control in the Caribbean region. And those are some examples of research that we have been publishing and being involved with. So with all of this, we have done what I think is quite a bit from over the last 5 years, 2015 to 2020. But as we all know, 2020 arrived and so did COVID to our region. So how can we facilitate the sustainability of cancer registration in this era? As you know, there are issues which threaten sustainability, and chief among that is competing priorities. We have issues with long-standing surveillance systems for communicable diseases or transmissible diseases, as you say in Spanish, and the competition with non-communicable diseases. And as I indicated earlier, limited understanding of the importance of cancer surveillance. So that's a challenge. We have increasing environmental concerns in our region. With climate change, we have increasing hurricanes, tornadoes, floods, and even forest fires, as you have seen, mostly in the United States. So with many times in our region, when we have hurricanes, because of the limited resources available, a lot of attention is then shifted away from cancer surveillance, away from non-communicable diseases, and even in this COVID period, away from dealing with cancers and giving priority to those emergencies. We also have situations that face us with limitation in resources both financial resources as well as human resources. And in our region, we have changes of governments frequently because we have elections in a cycle every 4 or 5 years. And again, when there's a change of governments, the priorities usually change. So that again is another challenge or an issue which threatens the sustainability of cancer registration in the region. Sorry, I'm going the wrong way. So we have established and continue to establish opportunities for collaboration. As I've indicated before, we are working with international experts, and we are also facilitating twinning between our more experienced registries and the less experienced ones. So we have pairs supporting each other with the hope that they can help each other to improve and to sustain what they are doing. As I indicated before, we have continued advocacy, and we have been doing that at the highest levels of government with our stakeholders. We have been using civil society as well, including our cancer societies and our cancer patient support groups. We have been involving the private sector, national health insurance companies, and the universities. As I indicated before, we have our GICR regional experts, so we are using them as trainers to train the registries in these areas of expertise. And more importantly, we are showcasing the data and advocating use of the data. So we are using the opportunities to highlight the cancer data that's being collected in the region. So this data is being used to provide feedback to the stakeholders who provide the data to the cancer registry, both in country and externally, at meetings, conferences, and webinars, in publications, in producing reports, and as you are doing here today, as continuing medical education for our students and even our professionals. We are encouraging the use of data by health planners for cancer prevention and control, as well as by researchers. And to do that, we have to use data sharing agreements. We are also discussing challenges with stakeholders in order to identify solutions. So to improve access to data, we are discussing how do you create legislation to make cancer a reportable disease. In terms of data quality, to improve data quality, as indicated earlier, we are using assessments of the quality of the data and providing recommendations for improvement. And for capacity building, we are using our experts, trainers from the GICR to build capacity in our cancer registry. So cancer data is important, as we all know, for cancer control, and it helps us understand the burden of cancers. We use the numbers and the risks to make factual decisions about priorities. So we identify new cases of cancers, numbers of deaths, numbers of persons living with cancer. We use information on risk factor, behaviors, and demographics to predict future cancer trends. And we can use local data to determine where to invest scarce resources for the greatest effect on cancer control. We also use the data to assess progress with cancer control, and the data contributes to the shaping of health policies for improved public health lowering the rates of disease, and helping to have a longer life. So that's all I have for you today. Please feel free to visit our website and I will answer any questions that you may have in the panel. Thanks very much for listening.
Thank you, Dr. Glenis. Excellent conference. Now, our next faculty is Dr. Fernando Rosso. Dr. Rosso earned his MD degree from Universidad del Valle as his internal medicine degree from Universidad del Valle. Infectious disease specialization from Stanford University and Universidad.
Okay, good morning to all. It's a pleasure to be with you this morning. I was the past director of the Clinical Research Center in Fundación Valle de Lili, and I'm an IED physician, an infectious diseases physician, and well, now I'm a COVID-19 doctor. So I want to share with you the experience of starting this cancer registry at the Fundación. I will start talking about our institution. We're a very young institution. We have 25 years of started our clinical duties in our place in Cali, it's southwest part of Colombia. Fundación Valle de Lili, it's a collective dream that many people from Cali got resources to start a new hospital, a high technological hospital, and an academic center. We started our attending patients in 1994. Now we have 4 different sites in Cali. We are a private non-profit institution, and we are an hospital, an academic hospital, and our educational partner is Universidad ICESI. So when we started this idea to have a hospital cancer registry, we had a lot of reasons to start it. Many of the previous speakers talked about the importance of having information from populational cancer registers, but having a hospital cancer registry is very important to improve the characterizations, clinical characterizations of patients, can identify different health disparities, especially on access of medical care, and to evaluate quality of healthcare, and try to see in our own land, in our own countries, to evaluate effectiveness of diagnostic and therapeutics, leading to some clinical information to feedback the clinical decision making from the different medical groups. Very important for our trainees fellows, giving feedback to public health decision making, and the possibility of having economic evaluation. It's very important. The burden of cancer in middle income countries. Many years ago, I met Luis Gabriel Cuervo. He was an epidemiologist in Bogota. I was trained in clinical epidemiology in Bogota. And at that time, they started a study of trying to see the cancer registers that were in the hospitals back in those years. And he tried to score them. And his main idea was trying to see what factors could impact in the maintenance over the time of these registers. So he scored them based in different parameters like human resources, quality assessment of data, technological resources, logical resources, political resources, and dissemination of information. Colombia wasn't in those days very data-driven. It was most like political-driven. Even today, we are very political-driven and not data-driven. So the dissemination of information, it was a very important issue. And if you see, only those hospitals who scored over 80 had some type of dissemination of information, but those who were under 50, zero dissemination information. So sometimes you have to think, why do you need the data? And what are you going to do with that data? Because basically the maintenance over time of having this information that for us is very expensive. We don't have sometimes the economic resources or the institutional support, must lead our desire of having a register. So based on that, and a lot of things that were growing in our hospital, at 25 years back, we were a cardiovascular institution, but the immediate needs of cancer lead us to be today a big cancer hospital. So now we are the larger comprehensive cancer referral center that provides multidisciplinary care for patients in southwestern part of Colombia. And during all these years, we have tackled to get a very smart and enthusiastic people around cancer patients. So we developed different strategies. And we thought that basically around the Clinical Research Center, we could start this project. Not on the pathology side. There has been like the common side where the cancer register started, but we decided to start in the Clinical Research Center so we could see different aspects and try to use different connections, administrative connections, and political wills to get this project ongoing. So we have all these different multidisciplinary care that goes from clinical and administrative help for patients, surgery, radiotherapy, statistics, pathology, and all this group work with us in the registry, but we're the registry center in the Clinical Research Center. So we developed a methodology to go through this to ensemble the register. So we have the population and register area, case definitions, data collection, data source, follow-up, and quality control. For our population, basically, we're a referral center, tertiary healthcare hospital, that it's in the southwest part of Colombia. Colombia has a lot of social and health needs, a lot of inequalities, but we have a a huge advance in public health and providing care to all the population. So now more than 90% of Colombian people have some type of insurance that can lead to get some medical attention for cancer. We have approximately 12,000, more than 12,000 patients per year, and around 4,000 new diagnosis cancer patients per year. We started the register in April 2018, and we started recollecting information from January 1st of 2014. The case definitions, we basically adapt IARC case definitions in analytic and non-analytic cases. Those analytic cases were those who we started the diagnosis and care of patients, and those no-analytic cases were those who were referred after their initial diagnostic and treatment to follow up or further cancer treatment. The data collection, we designed and created our own system. We call it SIRIC, SIRIC, from Spanish, that's Sistema de Información del Registro Institucional de Cáncer. And this data collection take place under recommendations of FORS, the Facility Oncology Registry Data Standards, our own national surveillance system, CIVIGILA. In Colombia, cancer has been, we have a surveillance, a mandatory surveillance, and other resource of information was that cancer in Colombia in our healthcare system is considered a high-cost disease, and we need information from clinical aspects and economical aspects, especially the costs of cancer attention. So based on our data sources are, we have the Department of Data Management. So we have IT people gathering the information, all the pathology and clinical laboratory department, the pathology reports, biomarkers. We have a epidemiological surveillance committee. So we have this information of mandatory notification records, and all the information of the cancer functional unit of the active cases detection and their follow-up. And all that get to the information system of the institutional cancer register. And then we classify them as analytic, non-analytic, and new cases and prevalent cases. The follow-up, it's based on a cancer functionality unit, basically the follow-up of the clinical outcomes, and the Department of Data Management. They are the responsible of managing and saving data. And now we have other like IDP, IT people and engineering trying to make some advances in data mirroring. We have different like steps in quality control. There's no standard method for this information, but we guide with comparability, the timeliness, the validity, and the completeness of this information. For us, it's very important, the quality control of this data. We have this information from 2014 to 2018, a total of around 30,000 patients have been treated in the Fundación. And this is the distribution of the different types of cancer: 15% breast, thyroid cancer, 13%, hematolymphoid, 12%, prostate, 8%, and so on. So, based on this information, we started to share the information with the clinical groups, and we started to see what was the most important information that we would like to know and to study further. Most of the patients, the top departments or states in our country, we have this influence of all the southwest part of Colombia. Usually, this is an area, and some states are undeveloped states. So we help them a lot, especially the state of Cauca and Nariño. But basically, the most important region is our own state, this Valle del Cauca. This has led us to put interest in the clinicians to see what they want to see of the data, and these are some examples of some scientific production that we had in the last year with other colleagues, with Luis Eduardo Bravo from the Universidad del Valle. This is one of cancer, gastric, and health disparities that those who don't have like a complete or a better health insurance will have a less, a worse survival. Or the survival in cancer, in gastric cancer, depend on if you have early stages or local advanced stages or metastatic stages. And then we can compare our survival with other places. So, for example, for our site, we can have survivals around nearly some centers in Europe. Well, I'm an infectious diseases doctor, so I see the cancer patients when they get infected, but there's some infections that increase risk of cancer. So this is some of our data that we presented in the ID Week in Washington last year regarding cancer among HIV patients. We still have, we will still struggle with this infectious disease, a very important infectious disease, and we have a lot of hematolymphoid neoplasm in these patients, and their prognostic are not so good. So, for example, for Kaposi sarcoma, our survival is not so good. We still receive patients in advanced stages of HIV/AIDS, or some interactions regarding other infectious diseases and cancer, as Helicobacter pylori infections in cancer, the relation with cancer with gastric carcinoma. Recently, we have put this paper is under submission to the Cancer Cause and Control of our experience of having this experience that we desire to continue. But it has been like a difficult process. It's not so easy as I presented. We have a lot of difficulties as high volume of information, multiple information sources, and how we have to gather to put all the information together. a limited follow-up at a hospital discharge. So some patients will change their insurance, and then we will lose the follow-up of many of these patients. Sadly, still in Colombia, patients will not stay in the same insurance company for more than 2 years. So sometimes it's very difficult to have the follow-up of those patients. Limited economic resources and limited human resources. The need of new platforms, technological platforms, and the need of people who know data mining to get like easier the information or doing the process more effective. Clinical and administrative commitment is something that it's difficult. Physicians and administrative people are very busy, and sometimes have their commitment is difficult. But I think that the most important aspect is the teamwork, and we have to have trust. Colombia has a large story of untrusted relations. We had a civil war for a lot of years, and basically we don't trust between the people. So we have to have a better work team within the institutions, but as well with other institutions that provide information, because information must is needed to action. And sometimes we have a gap with getting the information and not doing things. And that's one of the problems in developing countries. The idea of having a global registry, it's a very good one. It's a very good idea, but still we have to work on commitments and in teamwork. Here in Colombia, we use a say that's gana-gana, win-win. All the parts have to win, have to have some benefit for patients, for the institutions, so everybody can agree and help for this to the maintenance of this type of registries. So as Luis Cuervo, more than 20 years ago, I hope that these efforts will be maintained to have this hospital registers, and we hope that other hospitals in Colombia can gather and maintain their own hospital registers. Thank you very much.
Okay, thank you, Dr. Rosso, for your excellent conference. Okay, and now I would like to introduce Dr. Sergio Prada. He will be addressing our panel. Dr. Prada is an economist from the Universidad Javeriana, and he has a master's degree in economics of the environment and natural resources from Universidad de los Andes. He was a research associate at Impact International LLC in Washington, D.C. from 2010 to 2012. Actually, Dr. Prada is a chief research officer in Fundación Valle del Lili. Welcome, Dr. Prada.
Thank you, Doctora Angela. It's a great pleasure to be here with all of these distinguished speakers. And So in terms of time, I'm going to go directly with the question of the panel. And I will ask every one of the speakers to take a maximum of 2 to 3 minutes so that we can hear everyone and also close this seminar that is already a little bit taking more time than what we were waiting. So the theme of the panel is about the future of registries. So I think that's a very important question. And there are several issues around that you can also establish your opinions. So this is the question: what do you think is the future? How can we assure sustainability from different points of view, financially, data integrity, human resources, academic use, etc. So I would like to start with Dr. Piñeros.
Okay, thank you. Hello, Sergio. It's an honor to know you virtually. So, well, I didn't have too much time to reflect on this, but obviously we have reflected because sustainability is one of the key issues and difficulties that we face. Part of the challenges that I mentioned is to understand that governments need to understand that cancer registration is a distinct surveillance system and that it is the responsibility of the government to have an information system which the government can plan, can take decisions, and can evaluate, especially because for such a costly disease in terms of the cost, while for transmissible diseases, you have the cost in terms of the potential disease of a whole community. Here you have to consider so many other things. So I think that the model that Colombia has helped sustainability because many of the registries are in universities and also perceive some money and support from the government. Nonetheless, there are many things that need to be improved. So that is one of my main points, is like this responsibility of the government in surveillance of chronic diseases and cancer. And I will not take too much more time because I think I already have my minute and a half or something like this.
Thank you. Dr. Serban Nagoita.
Hi, Sergio. It's a little bit difficult for me to address this issue just because I work for one of the best funded cancer surveillance programs. So, but nevertheless, I mean, sustainability, it's an issue everywhere. And in my opinion, I think using new technology is maybe one way to improve or achieve sustainability of cancer surveillance. And again, I realize that not that easy because even using new technology involves heavy down payment many times, like invest in infrastructure to support this highly automated data collection. Nevertheless, the cost of doing business, electronically, digitally, it decreases. I mean, we can see this with, every day and every development. Like, for example, with what happens now, at least in the United States, with digital commerce. Information that I have is that, for example, even in less financially stable countries, using even cell phones to transmit information it's something that it can be considered. It might be probably easier, more sustainable to just send encrypted messages using cell phones that trying to do things using paper records or the more traditional development of databases in a central location, like one database in each hospital. So basically cloud computing or using a central database that will save technology at one location that will support operation at many hospitals or many data collection points. I think that might be one model that maybe countries around the world can adopt, basically trying to limit the development of or the investment in local systems and maybe using more cloud-based computing. I guess my few minutes are off, so
okay,
thank you for the question.
Absolutely. Let me go with Dr. Teresita Vega.
Buenos días, otra vez. Wow, an interesting question, because I too live in the United States and have always experienced an incredible amount of support. But I would highlight a couple of areas that I know stand out. Obviously, for sustainability, you need the government support. There needs to be laws and regulations in order for you to make sure that you fulfill the mandates. Technology is what can be leveraged today that I think would help enormously, realizing the challenges and the cost of technology to push this information forward. I often say that data quality is 90% of what we do. If we don't get the abstracting data correct, it's worthless. And 10%, which sustains us, is showcasing the data that we actually have. Any data that you can showcase is what sells the cancer registry. When I started working here 20 years ago, it would be as simple as providing a basic summary of cases to administration. It would be as simple as showing a doc who's a lung specialist or a lung surgeon and say, hey, these are the cases that you have and that you've been working. It's incredible to see the interaction and the teamwork that occurs when you continue to share your data. So that's where I would highlight 90% quality of data and 10% showcasing it. Today, Yale New Haven Hospital, which I'm very, very proud of, I've been here for 20 years. And as you know, not only is it the first cancer registry, but it has survived many difficulties and challenges throughout time. And I consider us to have the best data possible, including now the partnership with administration to capture COVID data for our cancer patients. We've come a long way, and I'm very proud of that. And I expect that Colombia, Fundación Valle de Lili, will also be in the same place in a short period of time.
Thank you, for sure. Now let me go with Dr. Brau.
Me parece que el país no necesita un sistema de cáncer nacional. Hay que fortalecer los registros poblacionales existentes, están colocados en sitios estratégicos y con modelos adecuados se puede hacer uso de la mortalidad para estimar el riesgo del país. Coincido con la doctora Piñeros que debe integrarse los sistemas de cáncer al sistema de información del país y que reciban financiación directa por parte del Estado. También coincido con el doctor Teban en que debe haber una inversión tecnológica. La inversión tecnológica debe orientarse a minería de datos y procesamiento de textos para poder y mejorar la interoperabilidad externa e interna. Debe fomentarse a nivel de los organismos de gestión de riesgo que las instituciones que tengan adecuado seguimiento de sus casos de cáncer sean beneficiados de alguna manera por los organismos, en este caso la cuenta de alto costo, cuando se haga los procesos internos. Me parece que es el futuro, y para mí el futuro de la información de cáncer en el país está en el desarrollo de los registros hospitalarios de cáncer. Debe haber una fuerte integración con el sistema nacional y el sistema nacional del país, con la avenida informática, con el CISPRO, donde se integre la información de otros sistemas de grandes bases de datos, estadísticas vitales, etc. Esa es la opinión desde los registros de cáncer.
Muchas gracias. Thank you, Dr. Bravo. Let's go with Dr. Glenis Andal Brereton.
Yes, thank you. I think I touched on a lot of the issues in my presentation to do with sustainability. I think for our region, Latin America and the Caribbean, I think the greatest or the most important thing, as Dr. Pineros indicated, is understanding why cancer data is important. So I think in this regard, using the data that's available to make the point to policymakers is important, so that they see what data can tell them or how data can be used to inform policy. So using whatever data is there, of course, for example, in our region, as I showed, we do not have many high quality data, cancer registry. So the data is best, but you use what you have to show to the policymakers. And again, to feed back to even the persons who report the data. So feeding back to the stakeholders, to the doctors. They may then be able to identify. But we saw many more breast cancers than you have in the registry. So then you can say, well, how can you help us to get better? So again, showcasing and using the data. Political will is important, but if they don't understand how important cancer data is, then they would not support it. So again, yes, there's a role for the government, certainly, but they need to understand why collecting cancer data is important. And again, supporting the registries in our region, this is critical. So continuous support, continuous advocacy, building capacity, so that the countries are able to collect, the registrars are able to collect the data. We heard the whole the issue, which was kind of promoted by the US, but certainly we won't be able to automate systems because the data of the quality of the data is variable. So unless we bring the data quality up, we cannot implement a system that would just automatically give us the data, because the quality will have to be assured that the quality of the data is good. So those are my contributions. I think it's critical that we continue the advocacy and we facilitate support for the registry.
Thank you, Dr. Glenis. And I'll go now with Dr. Rosso.
Oh, I think that we don't need only economical resources. We need like to get a better purpose of why we need the data. I'm not an oncologist. I don't work in public health. I'm a clinician and an educator. So we need data for the patients. So we have to find those stakeholders that are with that interest, but we have to show the data. the insurance companies, pharmaceutical companies, biotechnical companies, universities, patient organizations can get resources, but we have to show the meaningful of the data. So let's. I work in infectious diseases, and one of the big issues we have is quality and patient safety. One of our most important patient safety issues is regarding nosocomial infections. And recently we gathered a national meeting with a Colombian Infectious Diseases Society and trying to gather information related with cancer mortality. And it has a very big impact, nosocomial infections. So we have to see like different aspects of cancer patients' attention to get more information. I think that having good hospital based registers to get clinical data, quality of care data, and prognosis of survival of most of those patients can give us a lot of information so the patients can get better quality of care, and we can apply those changes now. So usually the difference between hospital doctors and public health people is the clinicians, we like to act now. So we need like more information. So stakeholders, we can get them, but we have to work in teams. We have to trust with the insurance companies would like to know what is the quality of care of many of those patients, and those who have safety patient issues that get like an overcost on their medical attention. So I like to have a broader view, and not only getting the data for the population, and there's this disruption between the clinical decision making and the public health decision making. I know that it's necessary to have a national register, but that doesn't help for the inside everyday decisions that the different clinical groups have to make. Most of the undeveloping countries don't have a culture around data. They don't see their data. They see the patients every day, but they don't go back and see their own data, their own experience to improve. So we need to have more stakeholders, get more resources, but giving more meaning for the information that we need to gather around cancer patients.
Thank you, Dr. Rosso. So thank you all for morning full of insights and really interesting points. We have learned a lot from your experience and from your lessons. I would like to then allow Dr. Angela to close this event. Thank you.
Thank you, Dr. Prada. Okay, I would like to close this space to exchange knowledge. I would like to thank all of you for participating in this event. We are also gratified to the faculty members, Dr. Piñeros, Dr. Negoita, Teresita Vega, Dr. Albreton, Dr. Rosso, Dr. Prada, and Dr. Bravo. They made this meeting possible and contribute to us with their knowledge and experience. Next, I would like to thank the Oncology Research Line at Centro de Investigaciones Clínicas in Fundación Valle de Lili, especially Diana Mendoza, Luis Parra, and Juan Falla, crucial members of the oncology team. I also want to give my thanks to ICESI's academic committee, under Dr. Luis Escobar's coordination. Also, communication department and audiovisual service. Finally, I want to express special gratitude to Dr. Marcela Granados for allowing me to be part of the Foundation Valle de Lili Onco team. We look forward to an upcoming